Good morning. My name is Ernest Cole. I am Associate Professor, Department of English, and I'm also Director of Global Learning at Hope College. On the 5th of January 2015, I'll be organizing a workshop as part of faculty development, and I've titled the workshop A Global Approach to Understanding Ebola, Implications for the Academy. It seems to me that given the predominance of the conversation and controversies surrounding the outbreak of the Ebola virus, two issues, among others, begin to emerge for me. The first is the global connections of societies, and the second is the fear of the spread of the disease. I think Ebola has unveiled the unfortunate reality that the world, through technological advancements, especially those related to mobility, business and communication, is more globally connected, perhaps in more ways than we previously imagined. At the same time, the limited knowledge of the disease and its mode of transmission has contributed to a climate of fear, if not hysteria, the world over. And so efforts by international agencies like the United Nations and the World Health Organization and Doctors Without Borders to contain the spread of the disease in the affected regions of the world has met with at times resistance, a lukewarm response by the international community, if response at all, and it's also been hampered by sociocultural practices relating to the dead in the affected regions of the world. So as an institution, I begin to ponder as the date approaches for a faculty development workshop on global learning. I said to myself that Ebola offers the academy a valuable opportunity to begin a conversation on global cause connections, not only geopolitically, but also from an interdisciplinary perspective. I am thrilled by the possibility of faculty making presentations on what seems, to be an isolated and medically constituted issue could be engaged, could be approached, could be taught for multiple disciplines across campus. Using this approach, I believe that faculty would shed the light on global cause connections and teaching and learning practices and pedagogies centered around an issue, of a global dimension. Therefore, in pursuing this objective, I intend to construct a workshop around a unifying theme across disciplines, but that workshop will be sort of driven by what I called a metaphor of touch. Since physical touch or bodily contact with the fluid of an infected person is critical to the spread of the disease, it seems to me that if I give panelists the opportunity to explore the absence of touch or touch in this context will be critical not only to understanding the disease, but how we relate to victims or affected individuals. But the crucial point here is how from our own disciplines we can speak to Ebola. For example, from a theological perspective, what does it mean to touch or to not touch a person? Or from a psychological perspective, given the predominance of fear of the spread of the disease, how does that play into the national psyche of both the affected regions and the international community? And how, by that notion of fear, we look at the politics of Ebola in terms of the international response or lukewarm response, so to speak. We also want to look at the history of the spread of the disease, how in fact, given the history of the plague and its literature, especially in medieval times, how we come to understand issues of continuity or complementarity or contrast. So to me, I think a panel of two sets of panels of three individuals that will speak to the nature of the disease, its politics, its psychology, its theological or religious implications, or from a nursing perspective, the caregivers, what it means to touch or to not touch a sick person will be crucial for the academy. And so I invite you all on the 5th of January to attend this workshop. It's going to be an interesting time for us as professors to think about how a seemingly isolated topic like Ebola could be approached from an interdisciplinary perspective, and what are the pedagogical implications for us as professors in the classroom. I'll invite you to listen to my 6 panelists and have a sense of what their presentations will be like. Thank you very much, and see you soon.
I'm Curtis Grindler, professor in the English department and the current director of general education at Hope. My special area of research is the Middle Ages, which might be a surprising connection to the current Ebola crisis. But one of the fascinating episodes of the late Middle Ages is the Black Death, in which a third of the population of Europe perished over the course of a few years, but it was even more intense than that in each community. It would go through over a period of a few months, and mortality in some places was up to 50% during that time. So it's interesting, I think, to ask what connections the plague of the Black Death might have with the current crisis. Lots of differences, of course, in the state of medicine, but maybe some surprising similarities. It's a bit of a renaissance of research on the Black Death, because archaeology is turning up lots of new evidence to set alongside the old traditional sources. Above all, Boccaccio's Decameron, a great work from the mid-14th century that begins with our best account of what it was like in the Black Death, where Boccaccio is pioneering what we now recognize as journalistic writing, and just recording all the different ways that people responded to the Black Death. But now with archaeological evidence, we can look a little bit more closely at who died, were there differences of mortality, how did different people groups respond to each other, were there social divisions that were opened up by the Black Death? So questions we can ask that at least might provide a new standpoint of thinking by setting the two alongside each other. And I think one of the interesting things about comparing the two is that in sort of the very long perspective, it's pretty clear that the Black Death led to various kinds of progress, we could say, in retrospect, or a revival, or a shaking up of society that was no doubt terrifying and grievous at the time, but led to some new things that in retrospect were opportunities. And maybe it's that kind of a perspective could be a source of some hope now as we live through and respond to a terrible period of suffering, and try to reach out to those who suffer.
Hello, my name is Annie Dendavadi. Of course, I'm sometimes called Professor Dendavadi or Dr. Dendavadi. I teach in the Political Science Department. I also happen to be the chair of the Political Science Department, and I also direct the International Studies program here at Hope College. The focus of my talk is going to be primarily on 4 or 5 issues that I've been grappling with as I've seen the coverage on Ebola, or the first time when this issue sort of hit the newspapers or even the local and international media. I want the Academy to remember that the best way to approach this issue is perhaps looking at it in the context of what we refer to in international relations as global issues. This has global as well as local connotations. We live in a world that is deeply interconnected, We've all been teaching classes on globalization and its impact, and here we have a specific sort of lab test case of a story related to Ebola. We couldn't have gotten more concise with an issue that would highlight to us the interconnectedness of the world that we live in. Our students and perhaps members of the academy, as they travel from one corner of the earth to the other, have to take their, passports and their visas with them. But germs and microbes know no visas. They do not respect these physical borders or boundaries that we may have created. So while this panel is fantastic in terms of dealing with its focus on touch and its focus on the impact that a quarantine or the treatment of this disease can have based on fear, I want our colleagues to remember that these issues are primarily interdomestic in nature. We cannot divorce the domestic repercussions of an issue from its international repercussions. The nature of the states in which they are found, and therefore the focus on primarily Sierra Leone, Liberia, Guinea, those unfortunate countries or places on this earth where this outbreak has taken place. What connotations does this have for a country like the United States, for members of the academy who live here, when we are talking about issues and levels of analysis that are interconnected at its very root. So I would like individuals to explore this issue both at the macro as well as the micro level. Of course, we have colleagues from the psychology department, etc., who might be looking at it from what it means for the person who is involved, either the caregiver, the care provider, or the person who has been unfortunate enough to be diagnosed or to catch this disease. But we also need to look at the responses of countries, of organizations. We want to look at how intergovernmental organizations like the United Nations have responded, how international financial institutions like the IMF have responded, and finally, members of civil society, organizations such as, the ones that the American doctors belong to, who then were able to come to this country for treatment, and organizations such as Doctors Without Borders or Healthcare Without Borders. What does all of this mean? So we obviously cannot look at Ebola in a vacuum, and it would be the wrong way to approach that issue, but we need to see it contextualized in a very highly globalized, interconnected world. Thank you for your attention, and I hope to see you on the 5th of January so that you can get a detailed understanding of how the panel approaches this topic.
Ben Kopak, Biology Department at Hope College, and I'll be discussing the biology behind Ebola virus. And I'll begin by discussing in broader terms how viruses are transmitted and how they're spread. And I will use examples from other viruses, including measles virus, which is spread very well through the aerosols, as well as influenza virus, which is spread through a respiratory droplet route, and HIV, which is spread through contact, blood-to-blood contact, or mucous membrane contact. And so I'll frame the discussion of Ebola virus transmission through those examples. And I will discuss how Ebola virus is spread and the biology behind how it is transmitted. And I'll begin by discussing the risk factors associated with Ebola virus transmission, Ebola virus spread. So how does the virus cause disease? What is the pathogenesis associated with Ebola virus infection? And how does that contribute to the spread of the virus itself? And Ebola virus seems to be spread through contact with bodily fluids from infected people. But what does contact of bodily fluids mean? Does that simply mean skin-to-skin contact? Is that skin touching the blood of an infected person, or the vomit or secretions of the person? And what does that contact mean for Ebola virus transmission? And I'll discuss the risk factors associated with the transmission. Can you get, is Ebola virus transmitted before a patient displays symptoms or that they're asymptomatic? Can you get Ebola virus during that period? Or can you only get transmission, effective transmission, after the person becomes symptomatic and starts showing the fever and malaise and other symptoms that are characteristic of Ebola virus infection.
Hi, I'm Susan Dunn from the Department of Nursing. I'm a professor here at Hope College in the nursing department. And I'm very excited to be part of this discussion regarding Ebola. It really is quite an interesting yet challenging aspect of what nursing is all about. Ebola, like any other infectious disease, of course, we think of the victims and their family members, and our hearts and prayers go out to them. But in thinking about nursing and other healthcare providers, there are almost other victims that I think about, and it's those folks on the front line that are caring for the patients and the family members. And how are they victims? Well, they absolutely have the potential to contract the disease, but they're actually a victim in another way, and it has to do directly to what Ernest Cole has put together for this panel discussion, and it has to do with touch. Touch being one of the key, most valued instruments that nurses and other healthcare providers use in caring for patients. And we use it to diagnose patients, to assess their skin, their internal organs, but more importantly, we use it as a tool of communication and a tool of caring for patients. And so what does it mean to a healthcare worker when a tool like that is taken away from them, and taken away from them because that instrument, that touch, could potentially kill them? So to have physical touch taken away is obvious, I think, to the public. And when you look at the hazmat suits that folks need to wear, I mean, how do you touch a person through that bulky garment? Even speaking to them is challenging. And so based on my own experiences, that can have a devastating effect to healthcare workers. I myself have cared for patients in the past with full-blown AIDS. AIDS to the point where there's a lot of body secretions flying around the room. So I myself have had to walk into a patient's room and down gloves, booties, hat, mask, goggles, and the feelings that I recall were feelings of stress and grief and also guilt, in that here was this patient who was so very sick and I couldn't touch them. And so I remember apologizing to those patients for my lack of being able to use what I perceive as one of the most valued instruments that we use in healthcare. So touch is an important topic in a lot of ways, and that's the perspective from the healthcare provider. And so I'm just so happy to be a part of this discussion.
I am Jenny Everts, and I'm Associate Professor in the Department of Religion at Hope College. I work in New Testament and Pauline studies, also in Charismatic and Pentecostal studies. And this summer I spent 6 weeks in England developing a course on global Pentecostal studies and writing an article on women in global Pentecostalism, especially in Africa and Latin America. And I was working with a man who has spent most of his life in Africa, and he had just had what I would regard as a fairly serious surgery. And so I asked him a little bit about the surgery, and he explained that the surgery was sort of an ongoing surgical process that had been going on in his life for 30 years because of a very serious car-truck accident that had occurred in Africa. And basically, when he was found on the road, he and his wife were found on the road by a Belgian priest who was working in Mozambique. He was taken, well, he was thought to be dying or dead, and he was administered last rites and put in the car. In the car with the Belgian priest was a doctor who had some morphine with him but was heading to the airport. So this was and he was taken to a bush hospital. And when he and his wife were in the bush hospital, they had the morphine from the doctor, but almost no other modern medical facilities. And they were on the border of a number of African countries, I think Zambia, Mozambique, Zimbabwe. And there were a number, they needed to be airlifted to modern medical facilities, but the modern medical facilities that were closest were in South Africa, and this was around 1985, 1986. And South Africa was, nobody wanted any South African airplanes anywhere in their airspace because of the apartheid embargo. And so he was there maybe 3 or 4 days and basically was crushed. His whole body was crushed. And he talked a little bit about what he remembers because he was coming in and out of consciousness. And his story has really stuck with me. He would, every time he came into consciousness, there was somebody with him, speaking with him, praying with him. If it wasn't the priest, it was one of the nursing sisters. He remembers other patients in the hospital coming over and sitting by him, making sure that he had something to drink. He remembers the orderly singing over him. He was never, ever left alone, and he was cared for. And of course, he was dying. This was the care that they were giving to a man that they thought was dying. And eventually he was airlifted, he and his wife, to South Africa, placed in top-notch modern Western care in separate hospitals. He didn't see his wife for several months. And he recovered. But the contrast between the care that he was given in this bush hospital and modern medical care really stuck with me, because he was part of a community of touch, a community of care, and you know, it was not at all clear that he was going to survive, and he was still given this kind of care in that community. And I came back to the United States just as the Ebola crisis was breaking in Africa, and I heard about all the modern medical care, the isolation, and it just occurred to me that this was the exact opposite of the kind of care that had been given to this man in Africa, somebody who'd spent all their life in Africa. And I just thought, what a change, what a crisis for those people who were having Ebola, that they would be isolated, that they would see people in masks who did not even look human, that they were cut off from their communities, that the touch, not just touch, but humanity, they were being deprived of humanity and community. And I just thought back then to the biblical models. I teach New Testament, I teach Gospels, and I thought about Jesus and the lepers, because the lepers also were isolated. They were deprived of touch. Biblical law required them to remove themselves from the community because of the fear of contagion. And we now know, of course, that leprosy is not a very contagious disease, but the fear of contagion was so strong that clothes needed to be burned, anything the bed they lied on needed to be burned. Everything about that needed to be burned, and so they went into isolation. And Jesus not only healed lepers, he spoke to them, he restored them to the community. He said, go to the high priest and make sure that the high priest knows that you're cured of leprosy. But the anointing at Bethany, when the woman comes in and anoints the feet of Jesus for burial, this is very easy to miss if you don't read the Gospels carefully. Jesus is in the house of Simon the leper. He entered the house of a leper. And so what we see here is a model that is being offered to Christians that has to do with touch, with presence, with community, being offered to people that are ostracized for various reasons in the community. And when he tells his disciples to go out and heal the sick, he specifically mentions the healing of lepers. And so when I think about the model that we have in the West of isolation and cutting people off from community for the fear of contagion, I really wonder if we're following biblical models, and especially the model of Jesus.
I'm David Myers in the Hope Psychology Department, and one thing that interests me is people's fears of different diseases and accidents. People often fear the wrong things. We fear things that are in the news that cause dramatic deaths. And so we often, for example, fear flying more than driving, even though we're like 170 times safer mile per mile on a commercial aircraft than we are in a car. Or we fear Ebola more than we fear influenza, which kills 24,000 Americans a year, while Ebola so far has killed no Americans who've contacted the disease here in the United States. So psychologists are interested in what causes us so often to fear the wrong things. And we fear what's readily available in memory, images of Shark attacks, for example, or airplane accidents or Ebola victims are very much available in our memory, whereas smoking deaths or influenza deaths are just not so vivid in our minds. We fear also things that are right now that are immediate dangers, like when we're taking off or landing in an airplane, rather than dangers that are distributed over time. And Ebola is very much right now. And we fear what we can't control. Influenza? Well, we can control that by getting a shot, we think. Ebola, that feels like it's totally beyond our control. We're helpless in the face of it. So there are a number of factors, these and more, that explain why we so often fear the wrong things, and why in the last political election, Ebola was such a political football. People in the United States way more afraid of it relative to other things than they should have been. While in other countries, such as Liberia and Sierra Leone, Ebola is a very, very big, much bigger thing.